Morning. Morning, everyone. Oh, just moved my green screen. Don't want to shatter the illusion. Hi, David. Good morning. Yeah, hope everyone is good. Right, I think we'll get cracking straight on with it. So we are just finishing up the hand, and it's the end of series 3. So the third time through the body. We're on episode 212, and yeah, it takes just over a year to cover the whole body. And just to put that into perspective for people, because I see a lot of times on social media, people are like, oh man, anatomy is really hard, and I'm struggling to remember everything. It's because there's a lot. There's a lot to do. And we've got some people in this group that this is their third time through with me. So for 3 years. And it's probably only really after about that amount of time where it starts to sink in. Yeah. It just takes time. It just takes time. So hence why I did the videos so people could watch them back yeah, just go over them until it sinks in. And also that this is, I've said this many times before, that this because obviously I teach anatomy every week, and I have done for 20 years. So when a patient comes in and there's an issue with whatever part of their body, then my anatomy is pretty good, and it's because I just do it all the time. Yeah. So if you're in private practice on your own and you don't see a hand and wrist patient for a year, your hand and wrist anatomy is going to be a bit rusty. So yeah, that's again what these are for. So you can have a quick look at the videos, bit of a catch up, and then when that patient comes in, then you're ready to go. So yeah, don't beat yourself up. I think because it's not easy. If it was easy, everyone would do it. Right, let's get you going. So we're going to do a bit of a recap on the nerves. It's probably going to be a bit of a shorter one today. Recap on the nerves, introduce the blood supply to the hand. There's a clinical test you can do to check that as well, and it links in with some of the other tests that we've done for the neck and for the shoulder. So yeah, you can add that in to your battery of tests that you do. And the title of this session today was why your hand goes numb. So there are lots of different reasons why your hand goes numb. We've done a few episodes on this because it can be something to do with your neck, it can be something to do with your shoulder region, and something called the brachial plexus, which is the network of nerves around this area here. It can be then down into the elbow, or it could be in the wrist and the hand. Okay, so this is the last kind of stop off, if you like, for those types of symptoms, and the last area to check. So if you are testing those things, then have a look back at some of the previous videos that we've done for the nerve and blood supply for the neck, for the shoulder, for the elbow, and then obviously today down into the wrist, because really you would need to check all of them to see if there's an issue with any of them, and then obviously refer to the correct pathway depending on what you find. So yeah, on my third evolution, still don't know it all. Will we? Who will ever know it all? Exactly, and we've got an anatomy lab visit coming up, and obviously I go along, and we have the clinicians from the universities there as well, and their anatomy knowledge is just phenomenal, and I learn from them when I go, and they're in there every day doing dissections, and that's all they do, and so they're on even another level. Yeah, so you, where does it stop? It doesn't stop, I don't think. I think it's continuous forever. Right, let's have a look at this then. So a bit of a recap. on this. Just get rid of that. There we go. So we looked at this last week, but I just want to go over it again. Just kind of finish up, kind of neatly package up the neurovascular bundle for this, or neurovascular vessels for this region. And like I say, the question, why does your hand go numb? Well, it depends which bit. And so if it's certain sections of your hand, and again, we did cover this last week, but we'll have a recap today. If it's certain sections, so certain fingers, then or the back of the hand, then it may indicate certain nerves. If it's the whole hand, you've either wiped out a number of the nerves, or it's a blood supply issue, which is quite likely. The length of time that it's numb for will give you a good indication as well. So if you sleep on your arm and you wake up because your arm's gone dead, as soon as you come off of the arm and you give it a bit of a shake, it comes back quite quickly. And that's because you've laid on it, you've cut off the blood supply. Usually that's the usual reason. And then as soon as you come off that blood supply and the blood can get flowing down to the area again, the feeling comes back. So it's usually quite quick. With a nerve compression, it can take some time, and if there's a pathology, then maybe not at all. So some of the symptoms and duration of things may give you an indication as to what is causing the problem as well. So median nerve. We were looking, again, like I said, we were looking at this last week. Just grab my arrow. So the median nerve is the one that's in the middle, hence median, and it runs down the middle of the elbow on the front of the elbow. So alongside the inside of the humerus, first of all, which is very, very close to the ulnar nerve. Hopefully this will be a bit of a recap from last week. And the ulnar nerve will take a slightly different pathway to the median nerve. So the median will come over the middle part of the elbow, and it will go in between the two heads of pronator teres. So we covered this in a bit more detail when we looked at the elbow anatomy. Then it will kind of rest on the interosseous membrane, which is the connective tissue that joins the radius and the ulnar bone together. So there's this like sheet of connective tissue, fascia if you like, that separates the front part and the back part of the forearm, and the median nerve will sit around that kind of area. Okay, so it's kind of, and the blood vessels as well, which we'll have a look at in a sec, use it as kind of like a bed. And then on its way down, it will come down around the wrist area here, and the median nerve goes all the way into certain fingers, which we'll have a look at in a second. It will pass underneath your carpal tunnel, which is the flexor retinaculum, and again another area of connective tissue. It's a thickened band of fascia that keeps all of the tendons and the vessels in place around the wrist. If it wasn't there, then when you bent your wrist forwards, when you go into flexion, then all of the tendons would just pop out like a pair of flared jeans. But because it's strapped in by this retinacula, that doesn't happen, and it creates a kind of pivot point, if you like, for those tendons to increase the efficiency of them working. Okay, because it's more like a pulley system then. Okay, yeah, we're looking at this region of the hands, of the thumb, the index finger, the middle finger, and half of your ring finger. Okay, so that's the area that the median nerve will supply. So here we go. Here's a classic picture. If you have a look on the internet and type in median nerve, then this is what you will usually see. So there are two main parts of the nerve. You've got the sensory distribution of the nerve, and that supplies the skin. Okay, so these are cutaneous nerves, they're called, and they're a branch off of the main nerve that come up into the surface and then supply the skin. So if you have altered sensation, it could be a numbness type feeling, a complete loss of sensation, an inability to distinguish between hot and cold. So you place something cold onto the fingertips or something hot, and they can't feel it. There may be an issue with the nerve there, and vibration sense as well. So those are some of the sensations that could be affected in this particular nerve. Now that goes a bit deeper into nerve testing, because the different sensations are distributed differently in the spinal cord. So on their way back up to the brain, vibration sense will go up one pathway, hot and cold will go up another, and light touch will go up another. So you've got all these different pathways in the spinal cord. When you do your neurological testing, that's what you're testing for, is those different pathways. So yeah, it's, if you can feel some but not some others, then it may be a problem further away from the hand. But again, it's one of those things where all we do is we do the tests, we know that something isn't quite right, so then we refer them on for further testing. Okay, if you're in the kind of role that I'm in, working in musculoskeletal medicine, then that's what you would do. And yeah, you report your findings and you refer them off to their GP. Okay, so you don't try and guess what is wrong with them, because it's impossible for us to do that without, I mean, sometimes it's even hard when they've had the test done at the hospital, they're still not really sure what the problem is. So we've got to be really careful. We're going, oh, if it's this, then they have this. If it's this, then they have this. It's very difficult to say for sure. So this is the area that we're interested in for the median nerve. So the thumb, the index finger, the middle finger, and then half of the ring finger. So if you've got a loss of sensation to those areas, there may be a compression at the carpal tunnel itself. Okay, so as the nerve passes through, so that could be because of some kind of edema around that area, so some kind of swelling, or it could be further up the chain. And again, we've looked at this in the elbow, we've looked at this in the neck and the shoulder. So have a look at those videos to get the whole picture of the pathway of this particular nerve. Okay, so and you would test each point to see where it is likely. Okay, so and that's an important term with what we do, whether something's more or less likely. Okay, so we've got the flexor retinacular over the top, which is the carpal tunnel. We've had a look at this before. We've got the tendons passing through, so we've got the flexor digitorum superficialis, flexor digitorum profundus. Those are your main tendons that pass through this area that affect the median nerve. All right, and you can see those quite clearly on imaging when you scan the carpal tunnel. The median nerve sits quite high on the tunnel. It's one of the most superficial structures. So if there's something pushing up from underneath, then the median nerve will get squashed against the roof, which is the carpal tunnel. Okay, so that's one of the reasons why it's affected. However, there are, I think, off the top of my head, at least 8 variations of the median nerve and its pathway around this carpal tunnel region. This is classic, okay, so where you've got the main nerve coming in underneath the retinacular and then it splits off into the fingers. You can have a split before the carpal tunnel. So part of the median nerve will go over the tunnel, some of it will go under. You can have several splits. Okay, so a couple will go over, a couple will come under. So that there's lots of different variations around this area. And that is why it's really difficult to work out what's going on sometimes, because you don't know whether someone's got an anatomical variation or not. Okay, but if you Google median nerve anatomical variations, make your Google search history wonder what's happened to you from the normal searches, then it will come up with a picture of all of those different nerve different anomalies. Okay, so the different ways that it goes. So the bottom of the tunnel is made up of the carpal rows, okay, and the tunnel will attach from the pisiform over to just underneath the thumb, so the trapezium, and onto the scaphoid, okay, so around that area there. And we looked at that when we looked at the bones of the wrist and the hand. Okay, the top of the tunnel is the flexor retinacular, which is this connective tissue here. Passes through the tunnel, we've already talked about that, and then a narrowing will give rise to the condition called carpal tunnel. And again, this has happened a few times with patients of mine where they've had these symptoms. They've had an operation done to cut this fascia, so to release the carpal tunnel, and it's not made a blind bit difference. Okay, so sometimes it's good, sometimes it hasn't made a difference. So that may mean that the compression, if indeed it is a compression of the median nerve, may be coming from somewhere else. And like I said, one of the places to check a little bit further up is in the elbow, pronator teres, where it passes through, and then up into the shoulder, it passes through your scalenes in your neck, underneath your pec minor. Yeah, so there's quite a few different areas where it can get irritated and may give you these symptoms. Also, these symptoms may not be related to the nerve at all. So we call this radicular symptoms. So when it follows the pathway of a nerve, if there's loss of sensation and loss of power, then that will be a radiculopathy. Okay, and if it, but it can also be referred, and that can be referred from another structure. So a joint referral is called a sclerotome. Yeah. Or it can be referred from a muscle, or it could be the nerve of the nerve is irritated. That's a bit confusing. So the nerves themselves have nerves that provide sensation to the nerve. Okay, so that if there's an irritation to the nerve itself, then the nerve of the nerve can get irritated and give you those symptoms as well. So there's loads of different things going on. Again, this is why it's hard doing what we do. So yeah, so that's your median nerve. Let's have a look at this video. Yeah, so hopefully I've gone into a bit more detail today because we've covered this previously last week, so it won't be brand new to you, so I can add in a little bit more sort of clinical stuff, if that's okay. And if you've got any questions, then pop them in the chat as we go along. So again, we watched this last week, so we'll just have a quick watch of this again. This is a pathway of the median nerve. There we go. There's the nerve there. There's your artery just above it. So nerves, you'll be surprised to hear from all the textbooks, they're not yellow. They are like a translucent sort of colour. They're a bit like, and I've said this before, apologies, everything in the body is kind of related to food. It's the only best way to describe it, I think. But they're a bit like the consistency of a really tough squid, like calamaris. Yeah, so it's that, but they're not as white as calamaris. They're a bit kind of yellowy, but not bright yellow like in the books. Okay, but there's your nerve there. So it's quite a thick nerve, the median nerve, and we'll have a look at the pathway as it goes through the forearm now. So in between your pronator teres, so the two heads of pronator teres. So one of the reasons, just pause that there. So one of the reasons that people will get carpal tunnel, and the kind of classic job to get it, is somebody who works at a desk all day and they're typing away and using their mouse, and then we give them those wrist supports to put their wrists on to help alleviate some of the symptoms in the carpal tunnel. But if you think about the position that they're in a constantly pronated position as well. So there may be some adaptive shortening with those, especially if you've been working in an office for 15 years or so. And so the pronator teres could be contributing to that restriction. And it's worth having a bit of a feel around that area to see if there's any tenderness or if it reproduces their symptoms in their hand when you push in and around that area. So again, just something to have a look out for. So here we go as it passes down into the forearm. So like I say, it's quite deep. So you're looking at just on top of that kind of interosseous membrane. There's all the flexor tendons, and it's poking through there. Palmaris longus on top. Here we go. So there's the retinacular, there's the median nerve, and this one's passing directly underneath. And then you can see the little branches coming off. Yeah, so these will be the branches coming up to the, some of them coming up to the skin, some of them the motor branches for the muscles. So these are the palmar digital nerves. They're going up to the fingers. And then we got one nerve there, and then all the others have got two. Yeah, remember loaf from last time? So remember loaf, we're going to cover that in a second. So here are your muscles that are supplied by the median nerve, superficialis, flexor pollicis longus, flexor digitorum profundus, and then down in the hand, here's your loaf muscles. Just get ready to pause this. There we go. Ooh, there we go. Okay, so your loaf muscles, lumbricals, opponens pollicis, flexor pollicis brevis, abductor pollicis brevis. So that those are your loaf muscles there. So they basically, the median nerve will supply this thenar eminence here. So if you have an issue with the nerve where the nerve has been interrupted, then these muscles can start to atrophy, because if you don't have nerve impulses going to the muscles, you can't use them, and you have a disuse atrophy, so they start to waste away basically. So if you one of the things you could do if someone is complaining of carpal tunnel, you can also have a look at their thenar eminence to see if there's any wastage of those muscles as well. There you go, perfect. So that was your median nerve. And then, yeah, so that's the area that it supplies in terms of sensory distribution. So like you said, half of the ring finger, middle finger, index, and the thumb. But you'll notice there are these patches here, yeah, and around the back of the hand, okay? And that's important for later, yeah, so as we add on the next couple of nerves. So ulnar nerve, again, just a quick recap, similar pathway to the median, but this time instead of going over the middle of the elbow, it comes around the medial aspect of the elbow and goes through something called the ulnar groove. The ulnar groove, if you remember, if you get your elbow point, put your middle finger on the elbow point, the thumb on the medial epicondyle of your humerus, and then index finger in between, and then there's a little groove in there, and that is where your funny bone is, which is the where the ulnar nerve passes through. So if you hit your funny bone, that's where you're hitting. It's really superficial at this point, so it's quite easy to knock it, and then you get shooting symptoms down into the hand. But it will be these two fingers that it will affect. Okay, so you'll feel it in those two fingers. And something that is quite common, actually, I get more and more people coming in with this now because they're looking at their phones in bed. So they're lying back in bed, elbows bent, and then they've got their phone near their face. And then they say, well, after a couple of minutes, my little fingers start to go numb. And it's because of the stretch on the nerve around that on the groove, and because of the irritation to the nerve in that position, it makes your little fingers go numb. But then as soon as you feel it come on, if you stretch your arms and shake them about, then it eases it off. Okay, but that's a classic at the moment. It's a modern day on the groove issue. So we've got the pathway of this then coming down the inside of the arm, so the medial aspect, and then towards your little finger and the other half of your ring finger. And here we are here. So it's just coming under there. You've got a ligament that covers over the ulnar nerve to keep it in place around the ulnar groove, called the Osborne's ligament. And that Osborne's ligament can become injured. And if that's the case, then you may get a flicking of the nerve, so it can come out of the groove. So when you straighten and bend the arm, you can actually see it and you can feel it so the nerve will pop out of that groove. This is the important bit around the hand. So the ulnar nerve doesn't go underneath the carpal tunnel, it goes over the top. It goes through something called Guyon's canal. Okay, you've got the hook of the hamate around this area here, and the ulnar nerve will pass underneath that hook. It's like a protective shield for the nerve, and then it will come out and supply your little finger. This is sensory supply, and the other half of your ring finger, and the motor branch of the nerve, so the bit that supplies the muscles, will supply all the other muscles in the hand apart from loaf. Okay, so the ulnar nerve does everything else pretty much. Okay, so that's a good thing to remember for exams if you are studying. So ulnar nerve, here we go. Just quickly go over this one again. Okay, so there's the nerve coming down there. Let me just pause that there. So yeah, there's your olecranon. There's your medial epicondyle, just there. And then there's the ulnar nerve coming through that groove. Okay, so you can see how superficial it is. Literally, there's just skin on top of that. So a couple of millimeters, some superficial fascia, and then skin. Okay, so it's really, really close. You can do a test. And again, the thing, title of the video is why your hands go numb. So if your little finger's going numb and your ring finger, then it can be you've knocked something here, or there's some irritation here, or in the palm. Okay, so where it passes through the Guyon's canal and then comes up into these fingers here. So there is usually affected by hand being squashed. Okay, so like cyclists, road cycling, especially because of the position on the handlebars, especially if they're on the drops, that position there will squash that on the nerve pathway, and it will make your little finger and your ring finger go numb. And you might see this a few times with cyclists. Again, might hear them when they're coming in saying their hands going numb, and you go, well, is it your hand or is it certain fingers? And it's probably those two fingers. If they're mountain bikers, because of the position and the kind of extended wrists, then often that's the median nerve that's affected. Okay, so it depends on the position of the hands as to which nerves may be affected. But around the elbow, it will be something to do with that area there. So some kind of compression or a stretch, like I said with the phone thing. So you can do a test on superficial nerves called a tinal tap. And when I very first learned it, I just thought it was one nerve which was a tinal tap. But you do a tinal tap on any of the superficial nerves, okay? And what you're looking for is a reproduction of symptoms. So if I can locate that on the groove and then I tap it, and if it's reproducing the symptoms into my finger, then there may be a sensitivity of the nerve around that area. You should usually be able to just tap that area, and it doesn't feel pleasant, but it shouldn't be too reactive. Okay, but if it's shooting down, reproducing their symptoms, maybe there's some kind of sensitivity around that point. So here we go. So this is down the medial aspect of the forearm, flexor carpi ulnaris, digital and superficialis there. So this is away from the midline of the forearm. This is more towards the little finger side. And then here we go as it's passing through. So you've got a branch which is coming up more superficially and supplying the skin, and then a deeper branch which supplies the muscles. So there's the cutaneous branch. And then there's a branch there. So superficial here, one nerve on that finger because the other one is median nerve, and then two on that one. And then the deeper branch will go down and supply the muscles of the intrinsic muscles of the hand. So there it is there, look. And it literally just inserts into the muscles like that. So you got interossei, lumbricals. That's really irritated my ulnar nerve. Demonstrated that. So we've got this distribution here of the little finger and the ring finger. So flexor digitorum profundus, the ulnar half of it, the hypothena muscles, so around this area here, all of the interossei, adductor pollicis, and then the ulnar lumbricals. Cool. Okay, so that was your ulnar nerve. Last one, and then we'll move on to the blood supply. So radial nerve, which wraps around the humerus, comes around the back of the hand and fills in the gaps that were left by the other two. So this is the pathway. Okay, so it's coming underneath the armpit. There's a groove in your humerus called the spiral groove. We looked at that when we looked at the elbow. Okay, so have a look back at the neuroanatomy of the elbow. And then it comes around the outside, so around that lateral epicondyle region. Yeah, we were doing some testing on this the other day. Actually, I was teaching a course where we were looking at nerve mobility, and sometimes if you have tension in a nerve, you can do upper limb tension tests for the nerve. So it's not a clinical problem, it's more of a functional one, where the glide of the nerve isn't great and it's a bit sensitive. Okay, so you'll get to it's a bit sticky, for want of a better word, in certain areas. And sometimes you can have someone come in with a tennis elbow, and you've been doing loads of strength stuff, you've been doing loads of soft tissue work, maybe using shockwave, and it's just not working. And if you haven't tested the radial nerve for tension, then that may be contributing to the symptoms. Okay, so it's another thing to check out. So again, if you've not seen those tests before, if you have a look for upper limb tension tests, then they'll show you how to do them online. So there's the pathway of the nerve. So we've got the muscle innervation, so the motor part of the nerve up here, and then the sensory part of it. There's a branch that comes all the way down and then supplies the back of the hand. So that's the dermatome. So it's the skin patch that the radial nerve provides sensation for. Okay, we've got these muscles that are motor as well. So the motor innervation. So abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus. So your thumb muscles are supplied. The dorsal thumb muscles are supplied by your radial nerve. Okay, so those three, and then muscles in the forearm, extensor digiti minimi, coming down to the little finger, extensor digitorum communis, so that's your digits, brachioradialis. Yeah, so all of those around there supplied by your radial nerve. So let's have a look at that. Here we go. And again, any questions, guys, give me a shout about anything. There's always usually a stunned silence when we do nerves and blood supply. So here's your radial nerve. We've got two branches. So the deep one is to the muscles. The superficial one is heading down to the back of the hand to supply sensation to the skin. So you've got your brachioradialis muscle. Again, we looked at that when we looked at the muscles of the forearm. And then there's your radial nerve coming down there. Over extensor pollicis brevis longus, and then there's a superficial supply for the skin. So you can see it's that area there, which is the last bit left. Okay, so median nerve is the other side of the thumb, ulnar nerve, little finger, and then there's your deep motor branch just there. Yeah, sometimes it's called the posterior interosseous nerve. It's the annoying thing with anatomy. Sometimes the same structure is given a different name in different books. So muscles, extensor carpi ulnaris, extensor digitorum indicis minimi. There we go, and then all your thumb as well. So the dorsum of your thumb. Perfect. Good. So that was a quick recap of the nerves. I think it's worth doing that because the nerves is usually quite an intense session when we cover those. And then we'll have a look at the blood supply. Perfect timing. So the blood supply is really cool. We've got two main arteries. So that again, we've covered the elbow and above in other videos. So we looked at the shoulder, we looked at the elbow supply. And then as the blood supply comes down into the forearm, it splits into two main branches. And we've got the ulnar artery. Guess where that goes? So that's heading towards the little finger. And then the radial artery, again, guess where that goes? That's going towards the thumb side. And then if you have a look down here, there's this interesting arrangement. Okay, so we've got a couple of loops in the hand. It's very similar to the foot in its structure. So this is it in a bit more detail. Let me just move me out of the way. So if we have a look here, so we've got RA, which is radial artery. So that this is coming along the thumb side. And then can you see where it's gone a little bit translucent there? So that's indicating that it's passing to the other side of the thumb. And then we've got a loop around, which then attaches onto the ulnar artery. And then if we have a look at the ulnar, it's coming around, looping, branches off to the fingers, and then around and attaches to the radial. So we've got this network where an archway will pass around the thumb and then come into the palm, and then another one will go won't go to the back, it will stay in the palm and do another loop, and they both join together. And it basically, if you've got an injury or have a problem with this artery here, this other artery can pick up the slack and fill in the blood supply. Okay, so we've got a deep palmar arch. So think about the palm. There's a deep blood supply to the palm, and there's also a superficial palmar arch. So this one here. So that it's supplying the next layer, if you like. Okay. So let's have a look at that. Let's get rid of those. We'll do that in a sec. Here we go. So this is the ulnar side. So little finger side artery this time instead of the nerve, but it follows a very similar pathway to the nerve. And here we are. Okay, so your olecranon on there. So this is the inside of a right forearm. Underneath pronator teres, flexor carpi radialis. There's pronator teres. There it goes there. Okay, ulnar arteries going there, and then there's a little branch going off there, the common interosseous. So in between the bones artery, common interosseous. Through, passes underneath the flexors. And there it is there. So it's coming up again up that little finger side, very close to the artery, to the nerve, sorry. They basically follow each other. And then there it goes there. So the one that we usually feel, if we're feeling for a pulse, is the radial side. And you'll see why in a second. It's more superficial. The ulnar side is quite deep. There's a few structures that are in the way, so you can't palpate the pulse as easily on that ulnar side. So there's your ulnar artery coming through. You can see all the little branches coming off that artery to supply the muscles. There's your flexor retinacular, and then it's popping out around the wrist here. There's the radial artery. Can you see there's two little branches there? One's coming towards the palm, one's going towards the dorsum, and then the ulnar artery around here. There it is. There's the superficial branch, and there's the deep branch. So this is that loop that I was talking about before. So we've got one going deep, one going superficial, and on both sides. But the radial wraps around the thumb, okay, and it pops through in a really cool place. I'll show you in a sec. And then there's the palmar aponeurosis. So we take that off, and then there's your superficial branch just there, because it literally is like just sitting underneath the palm of your hand. Joins with the radial loop, and we'll see where that pops through in a second. But there's our arteries going up into the fingers, and they follow the pathway of the nerves, because the nerves need blood as well. Okay, so it doesn't just supply muscles and skin, it's obviously the nerve network as well, and they go all the way up to the tip of the fingers. Okay, so that's your superficial branch. I just had a question here. Maybe it's a question, I'm not sure if I'm going to word this quite right, but how does the radial arch affect blood flow, direction, and pressure? I'm not sure what you mean, Becky. How does it affect it? It's it wouldn't have an effect either way, really. So they both equally supply blood to the hand. Hopefully that makes sense. Yeah, so because of the blood pressure coming both down both arteries, and then them both meeting together, it wouldn't negatively or positively affect it in any way. They're both kind of equal, if that makes sense. Hopefully that helps. Here's the radial artery. So this is obviously down the thumb side of the hand, and there it is there. Okay, and you can see how superficial this one is. Way more superficial. I mean, there's some stuff been removed there anyway, but they're way more superficial than the ulna, and you can palpate it around that area there. So if you're going to take a pulse, then it's always thumb side in that radial artery, because it's quite superficial. You can feel that quite easily. Yeah, that's your thumb side. Here we go. And then there's the split. So we've got one coming up superficial, and then one wrapping around the thumb. So there's your tendons for your thumb. Abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and then there's the artery there. So it's going through your dorsal interossei there. Okay, so that's basically that web space of your thumb. Okay, around there. Now, obviously you've got the artery really, really close to the web space, and I know that's an area where people put needles in. I've never heard of any problems doing that. I guess if you go for the center, then you'd be okay. But if you yeah, you might nick an artery if you get that in the wrong place. Yeah, let me just play that back again. Yeah, so the thumb is on this side, up here. There's the web space, so the muscle's in that web space, and then there's the artery coming through. So that will join up with the deep palmar arch from the ulnar side. Okay, yeah, that's a good way of putting it. Yeah, so two rivers joining together. Yeah, exactly. Yeah, but they don't really flow anywhere. I see what you mean, really, because it's a loop. It's not normally there's like one vessel, and then it ends up somewhere, and then that's the bit it supplies. Whereas this has basically got two supplies to that area. Okay, again, if there's a problem, then you've got backup. I think that's the good thing with this. And then last bit, so this is around the palm. This is where everything joins together. So you have the radial side wrapping around the back. Here we go. There it is there. And it pops through into the deep palmar branch. Okay, so you've got all the superficial stuff there. And then there it is taken away, and there it is there popping through there. Look. So there's your deep palmar arch there, and that links up then with the ulnar side. Just there. Cool. And then the last thing, just to show you, is the test that you had a brief look at. So this is Allen's test to test the integrity of both of those blood vessels. So you squeeze the wrist a number of times, hold it really tight. You occlude the vessels, so you squish the vessels so no blood comes through. Open up the hand and it'll be white, should be. There we go. And then you release one and then the hand goes red. So we know that the radial artery is working okay. And then you do the same again. So you pump the hand and then you hold it there, squeeze, occlude both arteries. So you're stopping the blood supply and then you release the ulnar side and it should go red. And it does. Phew. Okay, so that's how to test those, and that's why you do that, because of the loop. Okay, cool. That is third time round the body done. So we're on to the fourth time round the body next Monday, 10 o'clock. We're going to start with the foot and then work our way up and around over the next year or so. So yeah, hopefully you'll join me live every Monday. That'd be nice. Thank you for your questions today. If you got any questions after you've had a bit of a think about things and let things settle down a bit, pop it in the Facebook group and I can answer them in there as well. Okay, cool. I will see you next Monday, 10 o'clock.